Good afternoon, everybody, and welcome to this late-breaking plenary on the subject of health in all policies in the European Union, in the European Commission. My name's Kieran Walsh, and I'm a Professor of Health Policy and Management in Manchester in the UK, and a board member of the European Health Management Association. It's a delight to be asked by the conference organisers to chair this plenary session today. In a moment, I'm going to introduce our two speakers. But I first wanted to just say a few words about the purpose of the session. I think it's easy in this community, with its concern with public health, to focus on DG Sanco, the Directorate for Health and Consumer Affairs, particularly in our relationships with and work with colleagues in the Commission in that Directorate General. And speaking personally, I must say I find it hard to understand the full range of directorates and their work and its impact on health and healthcare. But we know that not only is there an expectation that health and public health concerns are to be reflected in across the policy spectrum in the work of the Commission, but we have lots of examples of times when the actions of other directorates general impact on health and healthcare. From my perspective as someone concerned particularly with health systems, the impact of single market provisions and their effect on patient mobility, on health professions mobility, and on funders and their sustainability is an important example of that from the past. A more recent one perhaps is the impact of the economic crisis on health across the European Union, but particularly in those states that are subject to the attentions of the Troika. And the impact of the actions on economic and financial policy and on employment policy on issues of health and healthcare. So I think the aim of today's session is to bring to this audience the work of other directorates general who have very important influences on and impact on public health. And we have with us two colleagues representing DG Enlargement and DG Research. So for DG Enlargement, our first speaker is Katja de Sadelaar, who's worked in DG Enlargement, I work out for quite a long time, for I think 12 years or so, and so has been there through the big period of expansion, has seen a number of countries through the process of accession, has been coordinating public health issues in the accession negotiations for something like 10 years, and who I know is currently involved in the negotiations with Montenegro. So Katja is going to speak first about the work of DG Enlargement, and then I'm going to turn to my other colleague, Barbara Kirsteins, who I think many of you will know because Barbara's spoken at this conference before and has spoken at some of our parallel sessions in this conference in these few days. Now, Barbara leads the public health section within DG Research and Innovation, and has worked in that DG for a relatively short time, but before that elsewhere in the Commission, and before that has a lot of experience in international public health, working for Médecins Sans Frontières and working at Johns Hopkins in the School of Public Health there. So Barbara is going to speak about the work of DG Research and Innovation, and particularly about its work around public health. I'd really like this session to be one in which people in the audience participate. So what I've asked our two speakers to do is each to speak for about 20 minutes, and then for us to have about 10 minutes after their presentation for questions and contributions from the audience. And we will have two roving mics, and the lights will go up at that stage, so there'll be an opportunity for you to contribute as well. So, with no more ado, Katja, over to you.
Yes, hello. Good afternoon to everybody. My name is Katja de Sadelaar, and I work, as Kieran said, in DG Enlargement. I have been working there since quite a number of years, since 2001. So I started with the accession of Slovakia and the other EU 10 countries, and then moved on to work with Bulgaria and Romania, and then also saw Croatia becoming an EU member state in July. And now, effectively, I'm working with the rest of the Western Balkan countries specifically with Montenegro. And I have been dealing with public health issues in DG Enlargement since 2001, when I had the country responsibility for Slovakia in this area. And then since 2003, I have been coordinating the public health issues in all enlargement countries, and specifically I'm in charge of accession negotiations. So this was done for Croatia, and now we have started the negotiations also with Montenegro, and soon most probably with Serbia. So what is the current enlargement agenda? As you can see here, well, we are covering currently 8 countries, Western Balkans, Turkey, and also Iceland. Like I said, Croatia became a member state on 1st of July, and now we are working with Montenegro. We opened the accession negotiations in June 2012. With Turkey, Turkey is negotiating since October 2005. The negotiations with Turkey were opened at the same time as with Croatia. With Iceland, negotiations started in 2010. However, they have now been put on hold because this was a decision by the Icelandic government. However, we are still, to a certain extent, dealing also with this country. Then we have other countries like the former Yugoslav Republic of Macedonia and also Serbia. And like I said, we hope to start negotiations soon. And then also we are dealing with 3 so-called potential candidates, and these are Albania, Bosnia and Herzegovina, and Kosovo. Some words about the conditions for membership. There are 3 sets of criteria to be fulfilled by the candidate country, and these are political criteria, economic criteria, and then the so-called ability to take on obligations of membership. I'm not going to speak about the first 2 ones, but I will focus on the last one. And the last criteria, actually, they cover the whole spectrum of the EU legislation, so-called EU acquis. And this EU legislation is divided into 35 different negotiating chapters. As you can see, consumer and health protection is there, number 28. In my presentation, I would like to shortly present our work in accession negotiations, and then also kind of give an overview on how we are monitoring the situation in the relevant countries, and also then mention something about the financial assistance we are giving to the countries as well. So, as you know, the overall aim of EU's health policy is to improve health and prevent human illness and diseases. And the EU legislation, actually, because this is an area which falls mainly under the national competence, so there is a limited number of legally binding instruments in the EU legislation. And then there is a larger body of non-binding measures and policy documents. And let's say the hard EU legislation mainly covers issues like tobacco control, communicable diseases, then the so-called substances of human origin, blood, tissue, cells, and organs. And also there is some recent legislation in the area of patients' rights in cross-border healthcare. And then the, let's say, more soft instruments are mental health, and then also areas like drug abuse prevention, health inequalities, nutrition, alcohol-related harm reduction, cancer screenings, healthy environments, including prevention of injury, promotion of safety, and rare diseases. And what are we looking at when we are kind of addressing these sectors? So we, in our work, we very much put the focus on the ability of the country to align with the EU legislation. So they should adopt legislation in view of aligning with the EU acquis. And then also what is, of course, very important is that they develop adequate administrative capacity in order to be able to implement and enforce this legislation by the time of accession. And maybe I say a few more words about the administrative capacity, because like I said, public health is mostly under national competence, so it's entirely, of course, for each member state to decide which kind of structure it will use. However, it should enable it to implement the requirements of the EU legislation. And in general, the public health systems in the candidate countries should become sustainable based on adequate organizational structures and financial resources, aiming, of course, at contributing to the health and well-being of the population. And this is largely a question of strengthening existing institutions in order to enable them to carry out new tasks. And also what we stress is that a sufficient and well-trained public health workforce should be ensured. So this is what we are mostly focusing on. And in a nutshell, I wanted to just show to you the steps from potential candidate to member country. So of course the potential candidate needs to submit an application for EU membership. The Commission assesses this, and then the Council decides by unanimity. Then we enter the phase of accession negotiations, and we are continuously monitoring the progress made in the country. And then finally, when negotiations are concluded, it's the European Parliament that has to give its consent, and then the EU member states need to sign and ratify the accession treaty. Now, if we look at the start of the process, so the opinion, or the avis as it's called, elaborated by the European Commission. So this we do on the situation in the applicant country, and there we assess also where the country stands in the area of public health. Then member states decide to open accession negotiations or not. And once the negotiations are officially opened, then follows a so-called screening process. This we are doing chapter by chapter. And this means that we have meetings with the candidate country where on one hand the Commission explains to the candidate country all the requirements related to the EU public health legislation in this case. And then we have meetings with the candidate country where they, on their side, explain to the Commission where they stand as regards legal alignment, administrative capacity, and also what are their future plans. And this process is currently ongoing with Montenegro, so we have carried out these meetings this spring. And now we are preparing a so-called screening report, which we will present to the EU member states by the end of this year. And this will include also the Commission recommendation whether the country is ready enough to start accession negotiations in this area. And maybe a few words about the readiness of Montenegro. Of course, our assessment is not yet final. However, what we can see already is that Montenegro has reached quite a good level of legal alignment with the EU acquis. For example, Montenegro legislation is already in line as regards tobacco control, for example. A lot of legislative work is currently carried out in Montenegro, and also we stress that the administrative capacity building needs to continue in order to ensure then due implementation and enforcement. With Iceland, this public health chapter, so negotiations were actually opened and provisionally closed in March 2012. Of course, this is nothing, let's say, unusual. There are no particular problems in Iceland in this sector. With Turkey, we have accession negotiations ongoing in this area since December 2007, when negotiations were opened with Turkey. We can see that legal alignment in Turkey is fairly advanced, and, but always when we open accession negotiations, then we also set some so-called closing benchmarks in view of closing the negotiations. This was also the case for Croatia, where Croatia needed to fulfill certain requirements before they could close this chapter. And with Turkey, for example, these closing benchmarks, they are related to the legislation on blood tissues and cells, where they should adopt legislation and also demonstrate adequate administrative capacity. This is already well advanced. Also in the area of communicable diseases, Turkey will need to demonstrate adequate institutional and administrative capacity, including its ability to participate in the early warning and response system. And also Turkey has benefited from the pre-accession financial assistance in this area. And for example, ECDC will carry now a mission in Turkey in 2014. So after that, we will know more about the situation there. And then we had also, with Turkey, we had a closing benchmark on tobacco control. This was related to the legal alignment. And actually there, Turkey is very advanced, so it can be already considered to fulfill this closing benchmark. It's also, of course, possible for countries to ask for so-called transitional arrangements in the accession negotiations, which means derogations to the application of the acquis, where they would extend or where they would align with the acquis only, let's say, after their membership. In this particular chapter, it has been unusual. It has only happened once in the accession negotiations with Bulgaria, where Bulgaria got a transitional arrangement in the field of tobacco control as regards the progressive reduction of tie yields for cigarettes. So this started from 2004, and it was in force until end 2010, so still 3 years after their accession. So from beginning 2011, Bulgaria should now comply with the EU legislation in this area. Then also what I will just mention is that of course the chapter is always provisionally closed following unanimous decision by member states, so we are entirely in their hands. And then all chapters are definitively closed only when all negotiations with the candidate country are concluded. And with Croatia, for example, this happened in June 2011. Then the follow-up, once the negotiations in a chapter are provisionally closed, we still, of course, continue monitoring the situation in the country, until it accedes to the EU. This we were doing with Croatia, for example. It was a twice-yearly exercise where we, at a very detailed level, we were following the commitments taken by Croatia in the accession negotiations. And for example, with Croatia, we were still closely monitoring areas such as the implementation of the recommendation on tobacco control, or in the area of communicable diseases, tissues and cells, also developments in the area of mental health, cancer screenings, and then also issues related to HIV/AIDS, and of course, administrative capacity development. Then, in general, apart from accession negotiations, because not, of course, all the countries are negotiating, now we are only talking about Montenegro currently, so we have tools to monitor and follow the situation in the countries. This is in a nutshell, so we produce a so-called enlargement package every year. And then we have also a network of agreements with the countries where we discuss different issues. And also, like I said, we can provide financial and technical assistance. So the annual progress reports by the Commission. So the last ones were published in October, and they are public documents, so you can find them under this website. They also cover developments in the area of public health. And this is, of course, a common work done by all the services of the Commission. And on top, we also consult international organizations such as WHO and also the NGOs. So this is really in order to try to be as objective as possible in our reports. Then there have been different international agreements concluded by the countries, and on the basis of these agreements, we are holding different meetings with the countries every year at different levels, so high level and expert meetings, etc. We can always, of course, organize more specific technical meetings as appropriate in case there are some problematic issues. And we can also organize so-called peer reviews, peer assessments, where member states' experts participate. And in the past, with Bulgaria and Romania, for example, we have carried out these kinds of peer reviews in the area of, for example, blood tissues and cells, and also covering mental health. And in the area of communicable diseases, more specifically in collaboration with ECDC, we have since 2012 carried out so-called assessment missions in the different countries. So starting with Croatia and Iceland in 2012, and we carried one mission to Montenegro this summer. We were also in Serbia now in the autumn, and like I said already, next year we will go to Turkey. Then I come to my last point, which is the financial assistance. So DG Enlargement is also giving financial assistance in order to help the countries to focus better, let's say, their accession path. This is called the Instrument for Pre-Accession Assistance, IPA. Here I have highlighted exactly the first component, which is transition assistance and institution building, because from the point of view of accession negotiations, it has been the most important one. Maybe some examples of projects that we have financed and we are financing Of course, the main focus has been, let's say, where we have most of the requirements of the EU legislation, like blood, tissues, and cells. These are also very technical areas which require different kinds of investments, etc. So these have been really, there have been most projects in these areas, like in the former Yugoslav Republic of Macedonia, in order to strengthen the blood safety system. Also in Montenegro, we have started a project in collaboration with WHO in view of helping Montenegro to implement their blood transfusion system. The same also in Turkey. And also in Croatia, we still have a project running on strengthening blood tissues and cells institutional capacity. Then in the area of communicable diseases, in Turkey, we have had also several projects in the past, and also projects still ongoing. Also in the area of legal alignment with tissues and cells and organs, and with alignment in organ donation, we have had projects in Turkey. Then we have had some general health projects, specifically in Bosnia and Herzegovina, where we have financed the reform of public health institutes, for example. And in Kosovo, we have been developing further the health information system. And in Serbia, we have had different projects, for example, the institutionalization project for mentally disabled people. Also, we have been helping them to develop the palliative care services and implementing their strategy for fight against drugs. And also, we have been helping them to implement the national cancer screening programs and also to develop health information system. And Croatia, even if it's already a member state, it will still be able to benefit from some financial assistance. And these will be targeted the implementation of cancer screening programs, and also we will help them to improve healthcare services for people with mental health disorders in community settings. And these are foreseen to start soon. This is the old EPA, because we are also developing a new instrument, EPA 2, which, unlike the previous one, will cover certain sectors. So it will be a sector-based instrument. So we are trying to identify key sectors where the countries are needing help. This is still under discussion. And the guiding principles are, we are trying to reinforce the link between the financial assistance and the policy agenda. And then we also will try to give more attention to the socio-economic development. And here also it covers public health, for example. But everything is still in progress, and funds probably will be available from 2015. So until then, it's still the current EPA instrument that will remain in force. And then as last
Katja,
point,
we're
I wanted...
at time.
Yes.
Just to say a few minutes.
And as the last point, I just wanted to mention the TAIEX facility run by DG Enlargement, which is the technical assistance and information exchange instrument, because of course pre-accession financial assistance, all these projects, they take time to develop and to design. So this is a more short-term targeted assistance instrument. It's easy to mobilize, and it's really targeted for civil servants, social partners, etc., to help them to participate in seminars, conferences, study visits, etc. And I have also put there the link where you can find more information. And here you have our links to the DG enlargement, different instruments. Thank you.
We've probably got time for a couple of questions. So if the lights could go up so people can see. Katja, do come back and join us here. Who would like to start? Got two colleagues with. If you can put your hand up, then I'll make sure that one of the mics gets to you. The usually vociferous public health community is unusually silent. Oh, there's a hand just there. Someone there? No, okay. I had one question, Katja, which is, there's clearly both a lot of scrutiny pre-accession and actually a lot of direct assistance provided pre-accession. I'm interested in your reflections on what happens to those countries once they become members, whether both the level of scrutiny and indeed the level of support is rather less.
Yeah, I would say that this really depends on the areas. I would like to just say that actually with Croatia, I pointed out this pre-accession monitoring we had developed before Croatia became a member state. And actually we were establishing very detailed monitoring. I mean, the monitoring in different areas was very detailed from our side. And once Croatia became a member state, we could kind of hand all this work that we had done to the different commission services so they could duly follow up. So, I mean, this is all we can do. And then, of course, once the countries become member states, so then the ball is entirely in the hands of other commission services like DG Sanko. Yeah. And there, of course, it then depends on the area where we have more scrutiny, where we have less. I'm also dealing with other issues like social issues and like in the case of gender equality, for example, we can see that after accession, indeed, the situation may have even deteriorated in the country. But then it depends if there is hard EU legislation in place or not.
Because clearly the greatest leverage you have is pre-accession. There's a question here.
Very much. One of the countries that you mentioned, and you will know which it is, and I know as well, the senior politicians have been allegedly complicit in tobacco smuggling. And in a couple of the countries, there are serious issues around corruption with profound implications for public health in all sorts of ways. And I know that you can't speak about specific cases, but in general, to what extent are you able to address some of those issues which in other countries that are now member states have persisted and have continued to give rise to concern within the European Union?
Yes, thank you very much for this question. I didn't mention corruption in public health sector in my presentation, but this is of course also very much present in all the enlargement countries. That's why, and I think it started specifically with Croatia, DG Enlargement has put a great focus on the rule of law chapters. So we are looking very carefully at developments in the area of judiciary in order to tackle issues like corruption, etc. And now with Montenegro, because there were certain lessons learned also from the accession of Croatia, where we tried to do our utmost to improve situation in this area. However, our commissioner considered that this really should be a special focus from now on for all the countries. So we have now established a so-called new approach. We have two key negotiating chapters we are following very, very closely. These are judiciary and fundamental rights, and also justice, freedom, and security, where we have a kind of a bit different path in the accession negotiations, I would say, where there are very many layers and very many steps and requirements that the country needs to fulfill. And we also now in the accession negotiations, we try to start first with these areas, because these are areas that need a lot of reforms, etc., and it's very time consuming, so that we can really focus on these areas, and then we have enough time in the pre-accession phase to address these issues. But these are now really in the heart of the accession process.
Thank you, Katja. We're going to turn to our second presentation now, and you might think the two Directorates General are really quite different, but I think you will see some parallels, and we'll see if we can draw out some common issues after Barbara's presentation.
Good afternoon. I would like to thank the organizers for having given me the opportunity to speak about research for health policies and practices, giving you some perspectives. But we'll start by speaking about the current framework program for health research. As I assume you all know, health research is funded through what is called a framework program. This is the 7th, so a multi-annual program for health research. And here it's a quick state of play with some figures in terms of inputs. 5.4 billion invested. This represents 1,052 projects with more than 12,300 people participating in the research, 3,600 and something organizations, and 124 countries. And trying to get at some idea of impact, we measured through our ongoing monitoring system, a self-reporting system. We can say that as of yet, there have been 10,000 more publications with 203 patent applications and 29 spin-offs. These are some of the tangible outputs of the research that has been funded, but represents only a small part of what we expect in terms of outcome. And notably for those like you, public health practitioners, you may not particularly be interested in the number of patents and spin-offs, but from a perspective of an institution that also helps you remain competitive, it might be a good sign for the small and medium-sized enterprises. Now, if we go to the public health research portfolio, we note there has been a growth in investment in public health research since 2000, and the current contribution stands now at 429 million. And under FP7, we have now 190 projects that have been funded, and 142 are still ongoing. So the impact of that research, or the results from that research, will materialize in the years to come. And in terms of field of research, it's both population health, so more the health promotion, disease prevention type of research, and then the research you may more particularly be interested in, health systems and services research. I thought you would be most interested in knowing what's coming up, which is the Horizon 20 Research and Framework Program, and coming up meaning it should start, if all goes well, in the negotiations around the budget in January 2014. And I thought it would be useful to recall a bit of the context under which Horizon 2020 was developed in discussion with the Council, the Parliament. A stalling economic recovery, changing demographics with an aging population, climate change and depletion of natural resources, and rising healthcare costs. And you're all familiar with these type of challenges. And what has been seen, looking at the past, is that investment in research and development is part of the solution to exit from the economic crisis. And notably, Sweden and Finland were doing quite well in terms of investing and results related to their economic growth. So that is why, under the negotiations on the multi-annual framework for the Union, Horizon 2020 is the new research program, and the member states agreed for a sizable budget invested in research, overall research, covering all the areas, energy, transport, and also health. Although the Commission had proposed a budget of 80 billion. The agreement that was found was just over 70 billion. And the aim for the funding of the research is to, one, respond to the economic crisis and see research and investment for growth and job creation, but also address people's concerns about their livelihoods, safety and environment. And a third objective is to strengthen the Union's global position in research, innovation and technology. And you can appreciate that there is a tension between these three objectives, reaching these three objectives. So the priorities are, first of all, through Horizon 2020, fund excellent science, contribute to industrial leadership, but at the same time address the societal challenges, so address the concerns of the European citizen in terms of their security, their health, their education and job opportunities. Under the Societal Challenges chapter of Horizon 2020, there's a specific chapter called Health, Demographic Change and Well-being. And that's where funding for health research is niched. And the challenges ahead are, like I mentioned before, that cancer, chronic and degenerative diseases gain a growing importance with an aging population. And related to that, health expenditures are increasing and they stand more or less at 10% of GDP, with a sizable proportion of that investment in health spent on chronic diseases. This means, in fact, that there's a need for innovation and transformation of the health systems and services. And this will take time, but it's like necessary. And also, the Union will need to catch up with global health innovation leaders. So these are the challenges we face, specifically for health. And through funding under this challenge chapter, the aim is to translate science to the benefit of the citizens, so make the link clearer from the fundamental research to the implementation research to positive outcomes for the populations, the people in Europe. We aim also to test and demonstrate new healthcare models, new approaches, new tools, so that's the innovation dimension that we would like to support through Horizon 2020. Obviously, there's a need to support healthy and active aging, but of course also to improve health outcomes and reduce inequalities. At the same time, also support a competitive health sector, an efficient sector. Now, if you look, and those of you who have read the societal challenges, and more specifically the health demographic change chapter, basically, there's been a change with the way funding for health research was structured in the past. You will see that it's an integrated approach with 7 focus areas, going from understanding health and disease to health promotion, disease prevention, diagnosis, treatment, different models for healthcare, and a specific area related to advancing active and healthy aging. But there's also recognition that there's need for funding for improving research methods, the gathering of data at a large scale, and better ways to exploit the data that are there, so to provide better evidence for health systems research, healthcare organization and management, health promotion, disease prevention. And in addition, through Horizon 2020, funding will be given in public-public and public-private partnerships that you will see below. You know, the Medicine Initiative Phase 2, the European and Developing Countries Clinical Trial Partnership, and the Ambient and Assisted Living. These are programs, funding, it's a programmatic approach with co-funding depending on the initiative, the industry, and the European Union and the member states, or the European Union and the member states. And when I speak about the member states, that can be at national level or at regional level. Now, in the context of Horizon 2020, the demographic well-being and health chapter, we are aiming for an integrated approach to address the key research challenges. And here we've just highlighted some of the challenges that, let's say, the community of researchers might face, but that are necessary. We feel that it's necessary to get to an integrated approach to address key research challenges. First of all, it's about breaking barriers, breaking the silos between different disciplines of research. They need to come together because we think that's the only way that an effective solution to our health problems will be found. So a lot of emphasis of multidisciplinary research, intersectoral approaches, recognizing also the fact that there is a need to build capacities, and notably research capacities, in different countries of the Union and beyond. Then, obviously, through research, we would like to generate knowledge, but it's important to also develop adequate tools. There may be, as of yet, we may not have the right measure to assess the perspective of well-being of a European citizen, or we may not have the right economic data collection tools to really get a picture of how the issues of equity or inequity are addressed, and inequalities. Then there's a need to translate knowledge to practice, and the realization was that maybe that was insufficiently done under the 7th Framework Programme. So there is a drive to ask the research community to go beyond the lab and into the practice, primary care as an example. And then what one of the criticisms that we received, that let's say the economic value, the technical aspects of costs were insufficiently addressed, or let's say not sufficient funding was provided to do so. So therefore you will see more emphasis also to the economic dimension and the cost dimension, efficiency and effectiveness. What does it mean in practice? That when Horizon 2020's first call will be launched, and that is foreseen for the 11th of December, you will see that the topics are described very broadly. There is no mention of a specific disease or condition, and the different topics go from health promotion, disease prevention, like I mentioned, to new organization of care models and practices. There's less prescriptive topic text, as used to be before. Also, you will see that there will be a system of 2-year work programs. So the first call that will be launched will cover the funding for 2014 and 2015, under the understanding that, of course, room needs to be created for changes in the 2015 proposals, depending on the situation Europe will be in then. And you will see also that there is a stronger focus on end users, meaning those that will benefit ultimately from the research, and requests for different stakeholders to be involved from the start in the design of the studies. What's happening there? Oh, sorry. Wrong button. Now, we're nearly December. The day before yesterday, the member states approved the work program 2014-2015. So this will enable us, because as you know, there's still no agreement, overall agreement on the budgets. But it will, when I say no overall agreement on the budget, I don't mean specifically the health research related budget, I'm meaning the overall budget for the Union and the multi-annual framework program. But what we will be able to do, seeing that the member states have approved the first 2-year work program, is to publish what is called an orientation paper, so to give the research community the chance to get prepared, so to speak, while waiting for the first call to be effectively launched. And like I said, we hope it will be possible December 11th. And then, depending on the time of launching of the call, normally the deadline for submission of proposals would be first quarter 2014 and likely in March. Now, you can get more information on Horizon 2020 on the website. You will see there. For those of you that would like to, that are in the process of developing proposals or would like to get funding, I suggest you look at the participants portal, and I put the link in there, because the orientation paper should, when it will be published next week, we hope, you can find it there. And then to find suitable project partners, if you're not already networking, these are a few suggestions. I think you know, but it may be also good to keep in mind that funding is very competitive. Looking at past experience, it's 1 in 10. Thank you.
As Barbara rejoins us here at the table, again, there's an opportunity for, we've got about 6 minutes or so, if I must stick to time and allow the next plenary to start on time, about 6 minutes or so for some questions or observations from the floor. So who would like to make a comment on all of that? Yep, there's just one over here. You can introduce yourself and then make your question or comment.
Georgios Margatidis from the small sister program of the research program. It concerns health system development. Many member states are reorganizing the system. Some are still at the first level. They still use, you know, the traditional building blocks in reorganizing primary care, working on hospital care, taking something out of the hospital. Other member states have been developing the last years vertical but disease-oriented programs, national cancer plans, national plans for Alzheimer, national plans for chronic diseases, and they are trying to use this to, again, reorganize. And with a view to the aging issue, we are trying to move one further step ahead on comorbidities and even more flexible health systems. Do you think it is possible, and this is both for Barbara and for the moderator possibly, to support leapfrogging? If you know that the trend is further down the line that what you might be trying to do today, would the research program be a good opportunity to see whether you can leapfrog to the next level, maybe, of reorganization of our system, if this is the way to go, of course, on a theoretical basis?
Yeah, thank you for your question. It was a point that I forgot to mention when I gave my presentation. I think, like you are mentioning as well, we all are aware that systems are under reform, are transforming, and research can contribute to providing information on relevant way to organize the health systems or reorganize them, making them more efficient, more, let's say, friendly to the patient and the citizen. But that takes time. So we definitely, there's an opportunity for experiments on leapfrogging, as you speak, and it will be, let's say, the onus will be put on the research community to come up with ways and means that they would think usefully transformation could be supported. Under the framework program, there's no prescription as how to be done, and so there will be a request for evidence of models that are efficient and patient-centered, and then it's up to the community to decide how they would like, what it would look like. We are also, we will be funding a foresight exercise, trying to identify
what are the challenges that come up in the future that will affect health and well-being, and which different factors ranging from climate change, nutrition, ICT developments would affect health, but also the way healthcare systems should be organized.
And there's one more question over there.
Mark McCarthy. On behalf of UFA, I have, as the research lead, taken the last few years to try to engage with the development of the research program. And one of the positive elements has been, in January, there was a consultation on two papers that the Commission had themselves commissioned about the research program in public health in all its ways. Barbara, could you say how those reports, which were provided by academics and people in our community, will now feed into the development of the Horizon 2020 program, promoting the public health agenda within the research directorate?
Yes, thank you for your point. The reports have been very, I would say, important in helping design the first work programs, and they should continue to do so. There are, let's say, a series of topics that are under the work program 2014-2015 that were as a result of the discussions that were held, well, the report of the experts, but also the discussion held during that workshop. But obviously, that's not the only input that was provided to us to help design the first work program. I think it's also important to realize that Horizon 2020 is a 7-year program, that what will be put up for call is for the first 2 years. And obviously, while one would want to do everything, cover everything in the first 2 years, that is basically not possible. So some choices had to be made, and let's say the work program 2014-15 reflects some of the priorities of now. But I think it's important that the dialogue continues with you people sitting here, the practitioners, because we will have to see where the priorities should lie in 2016. I think it's also important that it's not only, let's say, making funding available, it's also ensuring that the results that come up for the research are used. And that is quite a challenge, and we think we could play probably a more active role in doing so. So that is one of the discussion. And the other point in terms of public health research is that because, as my colleague Katja pointed out, the organization of health systems is a prerogative of the member states, we feel it's important to engage with the member states so that there are more synergies developed. The funding for EU research should be clearly spell out EU added value, and therefore also systematically we will be asking that the research takes into account the diversity of the European regions, so that also they're more likelihood to address the concerns and the problems of different regions more effectively.
That's great. Thank you, Barbara. I think there is a natural connection, actually, between where we've finished our discussion and the next plenary, which focuses on innovation. So I'd just ask you all to join me in thanking Barbara and Katja, our two speakers. I think there'll just be a couple of minutes break whilst we swap over for the next plenary.